Remember, the content on our show is for information only.
It is not intended to provide medical or other professional advice.
Hello, and welcome to Placebo, the podcast where each week my sister and I try and teach each other something interesting about healthcare or medicine. I'm Logan Richards, and this is my sister.
I'm Kaylin Richards.
And today, we're going to do an episode called Doctors versus Computers.
Oh.
But we're only going to look at one specific little part.
Doctor versus computer? Mm-hmm. Just not plural, maybe?
No. Lots of doctors.
Oh, okay.
Maybe only one computer.
Okay.
Have you heard of symptom checkers?
Like, are we allowed to say, like, WebMD?
We're not going to be able to avoid names this episode.
Sorry. Like, where you're like, oh, I have a sore throat and this weird rash. What's wrong with me?
Uh-huh. Yeah, so it's something where you go online, generally, and there's lots of apps for it now, too, but that's basically the same thing. You put in the symptoms
I probably have cholera.
You put in the symptoms that you're feeling and noticing, and then the computer
or meningitis
uses algorithms to give you random diseases that it thinks you might have.
Yes, probably fatal and very serious and very unlikely.
Well, so you're bringing up the first point is that symptom checkers don't have a great reputation. They're often known for, if you put anything in WebMD, you're likely to get cancer as a response, which in the majority of times is not cancer.
Yeah.
So we're going to talk about a couple of studies that look at doctors versus symptom checkers.
Okay.
What's your prediction?
I would hope doctors are better since that's their job. I
was kind of surprised by all these results, but I think I started with the same assumption that doctors would likely be better than these things.
Oh, no, are they not?
Well, so there was a recent report by what the research study calls the Institute of Medicine, but from what I can tell is the National Academy of Medicine, which is basically a non-profit, non-government group.
So when it says national, it's not really national to anything?
It's within the United States, and
okay.
They are within a larger organization that you've probably heard of called the National Academy of Sciences.
I've heard of that.
And so they just help make recommendations on science and medicine issues. So they put out a report recently saying that they were thinking that physician diagnostic error is common and too high.
Okay.
And so that's kind of what spurred this research that we're going to talk about. And there's a lot of technology companies and people working on solutions for how to make healthcare better through technology. So symptom checkers are one of those things, certainly not the only thing, but we're going to look at how well they work, if they work, and what kind of things we can take away from the results that they give us, I guess.
I mean, I would think that for either a doctor or a symptom checker to be accurate or helpful, the person reporting the symptoms has to be thorough and clear, because if they're not reporting some symptom that's necessary for diagnosing this disease because they don't think it's important or it's minor to them or whatever, then neither one is going to be accurate, right?
You are very true. And you're pointing out one of the key limitations that came up in both of these studies. And I'll just jump into it now, and we'll get back to it as I go through the order that I've written. So most of them, when they were testing out these symptom checkers, they had what they called non-clinical staff putting in the symptoms that you're supposed to be feeling.
So non-clinical staff in a hospital?
Meaning non-doctors. So it was people that they hired to take it's hard to do this without explaining the study, but basically They had non-doctors, non-healthcare person inputting symptoms. So they were trying to match the problem that you're saying here, that maybe someone who's not a doctor, not a healthcare worker, doesn't recognize the symptoms that are important or doesn't know how to describe them appropriately so that the symptom checker can figure it out, basically. Yeah. And they did come up against that problem. They said some of the time when they did a little bit of like a mini experiment where they gave some clinical words, basically, some really clinical terms. Like I remember they were saying like a certain color of exudate from the lungs or something was given versus, I don't remember what the other example, but just like maybe coughing up, gunk or something.
Yeah.
So the percentage of correct responses did change when they varied the words, and obviously when they used a more specific medical terms, the checkers did better. So that's an obvious limitation that you'll have to remember as we're talking about all these things.
Okay.
So here's the first study was last year, and the authors wanted to find all the symptom checkers they could that were in English. And basically they only allowed ones that were looking at general, like they didn't want anything that was too specific. So if the symptom checker was made only for orthopedic issues, they didn't include it.
Yeah. My ankle hurts. What's the problem? Like that would not be included.
They actually said that they decided to leave those out because the research shows that if you pick the right symptom checker that is very specific already, they actually do a pretty good job of diagnosing like certain types of things.
Okay.
And so they left out stuff like that. They wanted symptom checkers that were only made for general, non-specific. You just put in the symptoms and it gives you a diagnosis.
So like WebMD, right?
Right.
Okay.
So yeah, examples of that are WebMD, which I'm sure everyone has heard of, but they also had ones from the Mayo Clinic, Harvard Health. There's a popular app called iTriage. And then lots of others that I haven't heard of.
I haven't heard of any of those except for the WebMD one.
Okay, well, you've heard of the Mayo Clinic, though.
I've heard of it, but I didn't know they had a symptom checker.
Well, it seems like there's kind of 3 different groups of things that have symptom checkers. There's governments. So like National Health Service in the UK has a symptom checker, as an example. There's private organizations, so that would be WebMD. And then there's service providers. So there's
Mayo Clinic.
Yeah, but there's also ones owned by insurance companies. So I think that's what's in there. So like there's some owned by Aetna and other things like that, which is an
that where
insurance
you
company.
call? I mean, I guess that would be persons. That's where you call like the triage nurse and for your managed healthcare plan maybe and say, I'm not sure if I should go to the doctor or not. What
phone lines are not included. These are only internet things.
Okay.
But there are internet things owned by insurance companies and provider groups, like maybe,
I've heard like Kaiser, right?
Yeah. So that's
Group Health, which is a local HMO managed care plan.
So yeah, those are the 3 kind of categories that seem to be providing web-based symptom checkers: is private companies, governments, and provider groups. So what they did is they kind of ruled out everything and they came up with 23 symptom checkers. And then,
oh wow, is this worldwide or is this
only English? So some of them are from other countries, but they wanted ones that are only in English.
Okay.
So then they created these what they're calling like clinical vignettes. So basically descriptions of types of symptoms, and these descriptions don't have any physical exam findings or laboratory exam findings.
Wouldn't have that. So it's like a little case study, but just with the description.
A little case study. Basically, they're trying to replicate what a normal person might go in and tell a doctor, just the history kind of. And so they used, with the symptom checkers, they used these non-clinical staff, so people that weren't healthcare workers, to input the data into the symptom checkers. Total, they had, and I guess the other major category is they decided to look for 2 things. One of them they called diagnosis. So what's the likelihood that you're going to get the correct diagnosis from the symptom checker?
Did they compare it with doctors, or they're only looking at symptom checkers?
Not yet. Okay. Not in this study.
Okay.
But we'll get to that.
Okay.
So the one category was, do you get the correct diagnosis? The other category they called triage, and that's, does it give you the correct recommendation?
Regardless of the diagnosis is the thing
regardless of the diagnosis, right?
So if they gave you the wrong diagnosis, but the recommendation would be rest and see your doctor if you feel better, if you're not better in a week or something.
Yeah. So
then it would be still correct in that category.
Yeah, kind of what they're saying is like they gave an example which I'm forgetting off the top of my head now, but let's say like 2 types of maybe fevers that would require you to go to the ER immediately. They said, well, it doesn't really matter if the checker gets that right or not. What matters is that it sends you to the ER immediately.
You have a fever of 105. You need to go to the ER.
So, well, they were saying like it was like Rocky Mountain spotted fever versus some other type of something fever. So it's like it doesn't matter if it gets that right. It just it just matters if it sends you to the ER.
It understands that you're seriously ill enough. You need to go to the ER.
Yeah. So let's talk about the diagnosis category first. Mm-hmm. So they decided to look at this in a couple different ways. They took measurements for if it got the correct diagnosis. I guess, okay, so I'll go back. Most of the symptom checkers will give you a list of ranked diagnoses that it thinks you could have. Mm-hmm. Usually because there's lots of, variables. They know they're not perfect, so they're giving you a list. They say, here's the most likely, here's another one that's sort of likely, here's one that's less likely, on and on and on. So what they decided to do was say, does this checker give me the correct diagnosis in the first answer? Mm-hmm. In the first 3 answers or the first 20 answers?
20 is kind of a lot. I don't know if that's very valuable, but okay.
So what is your guess for the average of the 23 symptom checkers giving the correct diagnosis in the first slot?
Well, not knowing how detailed their vignettes are, I feel like probably not that great. Maybe 25%.
Pretty good. The average was 34%
okay.
across all diagnosis checkers that you would get the right answer on the first slot.
So like a third of the time it would be right.
Which is honestly
better than I thought.
Better than you thought. And keep in mind, this was done a year ago, so it's almost 100% likely that algorithms have changed and that all of these symptom checkers are at least slightly different. So they did mention that if you had a common condition, the percentage of correct answer on the first try was higher. And if you had an uncommon condition, it was lower. So that they had about a 50-50 split of common conditions versus uncommon conditions in their vignettes. Well,
and I would assume that's probably part of the algorithm built into the symptom checker, that they know that a cold is more common than, I don't know, with something with similar symptoms, it's rare. So that's going to come up more often just because it's more likely. Yeah.
Well, that's the classic like healthcare saying cliche. If you hear hooves, it's probably horses, not zebras. So
could be a zebra,
but so that's just going off of that. Like, it's likely the more common thing, which kind of explains that. One poor symptom checker got only 5% on the first time.
What's that one?
It was called, well, honestly, I don't know how to pronounce it. It's called Me Doctor or Med Doctor. It's the first 3 letters are capitalized to look like med, like medical, and then the rest are lowercase to finish it off with doctor. So it's either med, octor, or me doctor.
Maybe it's medoctor.
Yeah, see, well, this is their first problem. Clearly the name wasn't thought out.
Not good name recognition.
So they only got 5% on the first time.
That's
so
pretty bad.
Yeah, so maybe watch out for that one. Okay. Could be different. The best one in their study was a symptom checker called Doc Response, which got 50% of the time, which is pretty good for the first answer.
Okay, and then what about the top three?
Well, let's keep moving on. So across all symptom checkers, within the first 3 answers, getting the correct diagnosis. So there was 51% were in the top 3. 51% accuracy, meaning that if you had a certain disease, it would be 51% of the time, it would be in the top 3 answers on average.
I mean, that's not super great, though, still, because that's like a coin flip. That's like,
it's a coin flip, and it gives you 3 answers. So, like,
which could probably vary in level of severity.
It's a coin flip whether you even have access to the right diagnosis, but then you have the 2 others that it might not be.
Yeah. I'm not sure how helpful it is, really. Okay, keep going.
And then 58% for top 20. So not even that much better for top 20.
So really what that says to me is that probably look in the top 3. It's most likely to be in there. It's not greater odds that it's not that much bigger odds.
Not much better odds it'll be in the top 20.
Yeah, so probably if it's one of the things in the list, it's probably in the top 3, maybe?
But it also might not be one of the things.
But it might not be. Yeah.
So confusing. Okay, so let's kind of move on from there and go to the triage section that they
did it recommend the correct treatment?
Does it recommend the right course of action, basically? Okay. It's not giving you treatment, but it's telling you where you should go, if you should, go to the ER immediately or like rest and stay home, whatever.
Okay.
So four of the symptom checkers on their list, they said they always advise that you go directly to the most emergent form of care, meaning they always said go to the ER.
That's not the best method of healthcare.
So they took those ones out.
Okay. They just always said go to the ER?
Yeah.
You have a cold, go to the ER. No, don't.
I think for their study, they were saying that they decided... So a lot of symptom checkers will give you various options on what you might be able to do, and this is probably a legal thing.
They don't want to say you're fine when just in case you might be wrong.
Right. So I think those ones were saying, they and then the study they said, well, we need to take the most emergent option that is always given. Meaning that if ER is given, we're going to take ER as your response.
So they would say, depending on how you feel, maybe stay at home for a few days, or if you're really not feeling good, go to the ER.
Yeah.
And they would take ER.
Yeah.
Okay.
So it's not necessarily that they were always just saying, go to the ER. Okay,
because, people might have the flu and be fine to stay at home and recover, or they might be have a really high fever, and that could be dangerous, and you should go to the ER.
Yeah. So they took those four out to try and get a better measurement.
Okay.
And they did find that appropriate advice for triage was given 61% of the time across the average.
Well, it's okay, but it's still not super great.
So you have to think about this, though. The thing that they said is that even though the appropriate advice wasn't given, these symptom checkers are always risk adverse, meaning that
they don't want to be sued.
Usually the advice was more emergent than it needed to be.
Which is, I guess, if you're going to err on one side or the other, that's where you want to err, especially as it's the side of a business or organization.
It has to be legal issues that they're doing that.
But I would also say in the U.S., there's a problem with overutilization of emergency healthcare services.
Yeah.
So that's not great either,
And there's no more kind of relevant data on that. Because basically all of them are doing the same thing, kind of suggesting a higher option than is necessary.
Right.
But they're probably doing that for legal reasons.
Right. So
do you want to know what the best symptom checker for diagnosis was?
Yeah.
I'd never heard of it. But so for this study, the best symptom checker for diagnosis was called Isabel, made by a company that's called Isabel Healthcare.
I've never heard of it. It must not come up on the top search results.
I looked at their website, and it's like a very averagely designed website.
How do you spell
kind
it?
of clunky.
It says symptom checker, the one the doctors use.
But yeah, that might actually be true because their rating for getting it right in the top 20 results was 84%, the highest out of any of them, and about 10 percentage points higher than second place. But in this study about a year ago, it was the best one. Okay, so the first question that I kind of want to bring to you after we've only talked about the results of the first study,
looking at the symptom checker,
is that what should we really be expecting from a symptom checker? This is a question that they bring up at the end of their research, saying, what are we comparing a symptom checker to? What do we need it to be better than? Do we need it to be better than...
Well, a doctor, right?
Well, that's the question. Do we need it to be better than a doctor? Or do we just need it to be better than typing in your symptoms into a Google search and looking at the first couple of websites? Or do we need it to be better than a nurse hotline? Or do we need it to be not good at diagnosis at all, but better at triage suggestions and not even worry about if it's getting the right diagnosis?
Well, I feel like your last point is maybe the right one, triage, because you should always go to your doctor if you have something going on that you think needs to be checked out, right?
Right.
And I think the important thing is this an emergency? Is this something that should be seen to next week? Can I make an appointment and just discuss this at my physical in 2 months? How urgent is this problem? I think that's the more important thing because, you can look at a symptom checker, you can Google things, but you can't and you shouldn't try and diagnose yourself. That's not a good thing to be doing. I think a lot of times people, will make up their mind about things before even speaking to a doctor, and that's I don't know if that's how good that is or not. I mean, not to say doctors are incapable of making mistakes, because there are, and you should definitely stand up for yourself in your healthcare. But I don't know.
Okay.
I don't feel like we should expect a computer to be able to capture everything that a human can do.
No, and that's the other thing is with these vignettes they put in, there was no comorbidities. They didn't get a lot of extra information that might change the way that you would either treat the diagnosis, or maybe it would kind of bump up, a certain comorbidity would bump up the chance of a certain type of other diagnosis that the symptom checker could have made.
Because what if someone's having, for example, like a wound that's not healing on their foot, but you don't know that they have diabetes also, and they don't put that into their system checker?
Right.
Like, that kind of changes the whole picture.
Right. So
but
I think,
maybe not the triage of it.
I think there's two things, and I think what this study kind of concluded was the symptom checkers need to be as good as or better than nurse hotlines. Because that's
the other thing people do.
That was kind of what they're suggesting basically is that's kind of the way of the past of where you decided if you needed to go see a doctor or not.
By calling the nurse hotline, and they'd be like...
Yeah, but now that everything is internet-based and controlled by these algorithms, they think that that'll be kind of the way of the future. People will check that. And so what they're suggesting basically is it needs to be really good at triage suggestion.
Oh, see? I was right on.
Yeah. And it needs to be better than or at least the same as nurse hotlines. Because they think it'll kind of switch to that.
Because a nurse hotline, again, is not probably they're not trying to diagnose someone. They're trying to say, you need to go to the hospital. You need to make an appointment and see your doctor in a couple days.
Right.
Yeah.
The other thing that I think is really cool about this is that it seems to me like there would be two good categories, and I'm sure there are, two good categories of symptom checkers. One for patients, people that want to know what to do with their symptoms, but there should also be one for healthcare providers, and I'm sure there kind of already is.
Well, on the Isabel Symptom Checker website, on their homepage, it says, we are used by doctors and nurses.
Yeah.
So they're trying to put themselves forward as something used by doctors too.
Right. But I think what's important there is that it's almost could be used as a good tool for doctors to augment their ability to make a diagnosis so that they already have a bunch of stuff in their head. They know maybe what information the computer needs. So there should be two different tools designed differently almost, one for patients and one for doctors. But that seems like an interesting way to take symptom checkers.
And when I just was curious to click on like when I did the symptom checker for Isabel and I clicked on multiple sclerosis to see did they have a triage recommendation? No, it's just...
Well, not all of them make recommendations.
It doesn't make any recommendations.
I remember Isabel was one of the ones they took out of their study, the triage part of their study.
Yeah, it just comes up with information from different, I would say, maybe accurate and less accurate web resources, because they have up-to-date. That's a good resource.
Yeah.
They have Mayo Clinic. That's a good resource. And then they have Wikipedia, Google.
Which Wikipedia is not an awful resource most of the time.
Well, sure, but you have to take it with a grain of salt,
Yeah. It's not as bad as it used to be.
No.
Okay, so let's move to
anything online, take it with a grain of salt.
Yeah. Let's move to the second one. So a year later, the same research group decides that they want to put their results that they got on how well symptom checkers work to the test against real doctors.
Yeah, that's great.
So they used a website called HumanDx, which is just the medical abbreviation for diagnosis.
Yes.
So Human Diagnosis, which is a website where you can post symptoms that you're having maybe, or you have to be a doctor and you can...
It looks to me like it's for doctors.
It is for doctors, so the users are doctors. You can post... Basically what they did is they posted the clinical vignettes. I think they worked with the company and gave them the same vignettes that they used with the symptom checkers.
It says here, share your medical insight with the world, and then there's a button where you can contribute cases. So I think it's like...
Okay, so they contributed the cases.
If you maybe have like a confusing patient, you're just not sure where to go, maybe you can ask for input from other doctors or something.
Yeah. So they got 234 responses from doctors. A majority of them were... board certified in internal medicine, and then there was kind of a spattering of other doctors. And not surprisingly, what do you think the results were?
Doctors did better?
They were correct more often.
Please?
Yes.
Okay.
Okay, so here Okay, so across all the vignettes, the doctors were right the first time on 72.1%.
Good.
And
That's a lot better.
just as a reminder, the symptom checkers average was 34.
Okay.
So about twice as good, right?
Good, yeah.
Then moving on to did the doctor get it in the top 3 diagnoses? The doctors got 84.3%. And as a reminder, the symptom checkers on average got 51.2.
I mean, that seems about what I would expect.
Yeah, so that is good. And this kind of brought up the point even further that maybe there should be a separate tool designed only for doctors and people making diagnoses to augment their decision making. Can we take that 72% on the first try, use a symptom checker type of tool, and turn that into a 95 to 100% on the first try?
I mean, and I think, I don't know how they took this into account, but the experience level of a doctor probably makes a big difference as to how accurate they are, especially on the first try or the third try, because a new doctor just doesn't have the real world experience that a doctor that's been practicing for 25 years has. And so I would expect a doctor that's been in practice for 25 years to be more accurate than
better.
a newer doctor.
So maybe these symptom checkers for doctors would be even more important for newer doctors because they could kind of augment that lack of experience.
You get the experience of a ton of colleagues that
Yeah.
way. Because, I mean, I'm not a doctor and I didn't go to medical school, but I do observe the medical training system.
Yeah.
Because we are a teaching hospital. So I'll see, like, the doctors will travel around in a little pack, and there'll be, like, a attending, which is a doctor that's maybe, more experienced. It's been working for a long time.
They're the leader. And then you'll have maybe various levels of residents, and, like, an intern is the earliest level, and then there maybe is a second-year resident or a third-year resident, and then maybe a medical student would be the kind of bottom of the chain. Yeah.
So they all work together and kind of report up to the attending, who then will kind of finalize their recommendations or give them other things to think about. Or
Right.
That's kind of what I observe anyways. So I think that is to help give that experience to the newer doctors coming in. They'll kind of teach the ones that are younger than them or newer than them. Oh, did you consider this? Or in this circumstance, you should think about this. Or
Right.
Yeah.
So that's kind of a good point, though, into what my last point that I want to talk about is that the way that the medical system is working is shifting towards a system that's going to be more reliant on computers and algorithms making basic decisions. There's been a lot of research that I looked briefly into, but not in enough depth to talk about, on how well computers read ECGs or EKGs, whatever you want to call them. So those are the rhythm strips, for your heart.
Yeah.
And they're actually doing a really good job of that right now. And so that led me to this article in the Wall Street Journal by a doctor whose name is Eric Topol. And he was talking about one of his patients had an app on their smartphone and these electrodes that were connected to a system that would talk to his phone. And the system told him that his heart was an AFib. And he called his doctor and said, "I'm an AFib now. What do I do?" So there's a lot of... And so that right there is the medical system relying on an algorithm to make that's not technically a diagnosis, but to make an observation of symptoms that used to only be done by a person,
Right. I mean, if I was his doctor, I think I would say, you need to come in so we can test you and see how you're doing, because I don't think I trust a phone app necessarily. I mean, that's maybe a point to be concerned about, but you should come in and be tested by the equipment that we have in our medical facility, right?
So, yeah, it seems like, and I would imagine that a lot of doctors would agree with you on that point, that, well, the machines can be used, the computer algorithms can be used at this point to maybe point out certain symptoms and do really easy analysis that they're likely not being completely, used for making analysis of medical decisions without, which is kind of, at this point, is a smart way to go for anything, not just medical. If a computer is making an analysis on something, it's best to put your own reasoning behind it before you trust that analysis.
Sure. Because, I mean, there's the art and science of medicine or anything, right? And I think maybe the computer is fairly proficient at the science, but the art part, it's going to have a really hard time.
Right. Well, and that's just dealing with the complexities of humans, which we've already talked about. Most computers are yes, no, kind of true, false, and they take everything into account, and everything has an answer of true or false, and that's not really how it works in medicine. Yeah,
and maybe they can give probabilities, but you're the one who has to make you as the medical provider, or as the one who has to make an actual decision, or...
Well, and I think computer, programmers too are working on different forms of kind of logic for the computers, so they're not always going off of true or false anymore, but a lot of that stuff is in development. So if you're interested in learning more about kind of cloud computing and algorithms and the different things that are being used now, there's the Wall Street Journal article called "The Future of Medicine is in Your Smartphone," which I found really interesting reading, but there's not a ton of research in it yet. And at this point, it's a year old, meaning, with tech, who knows how accurate it is at this point anymore. But it's a really well-written article, and I think he's also written a book on the topic. If you're interested more on technology, analyzing medical data, and making some type of analysis. So that's where I'm going to leave it at this point, because all I did was just read those two studies.
Oh, don't say all I did.
Well, the only real research I did was those two studies. So as usual, there's a whole bigger area that would have, is interesting to look at, and you can go into more if you want to.
I feel like it's always that balance between how much do you want to give over your trust entirely to a computer versus a person. And I think you and I were talking about the driverless cars the other day, and how much that makes people uncomfortable sometimes. The idea of a driverless car, even with the cars where it shows that they are safer than people. It's just that idea of giving your care over to a machine that just doesn't feel right.
Right. Yeah, I think there's two main issues. That's the first one, is that, can you really trust this algorithm to make the right decision for you?
Because I think we've all probably personally had too many experiences with the computer just not working the way it should.
Yeah. And the second one, I think that a lot of people are worried about these days too, is privacy, especially when it comes to medical stuff. Do you really want your medical data and maybe, some type of medical decision that's being made up, connected to the internet, therefore vulnerable to hacking in some way?
Right. So anything can be hacked if someone decides they're going to do it.
And I'm not sure why, but let's say you're using that internet EKG reader and someone hacks it to make it so that it doesn't alert your doctor when you have, VTAC or whatever, then that's a real problem, obviously. So it's the same type of thing. It's a little bit different, but it's basically, can we trust,
Yeah, I don't know. And I mean, probably no one would care about our health information, but if we were, movie stars or politicians or important business people, I think people would try and take advantage of that.
Yeah.
In various ways. I don't know.
The other interesting thing that this article brings up that I kind of want to talk about later at another episode is that he's suggesting that hospitals eventually will only be ERs and ICUs, and everything else will be self-monitored using this kind of technology from another location, so not at the hospital, whether it be home or some type of longer-term care facility.
I would say, of course, the problem that brings up to me is caregivers, because a lot of people just can't leave the hospital, and partly because they're sick and they need the monitoring and stuff, but partly because they're so sick and they can't be cared for at home,
right. So, interesting again, but he's saying we have the technological capability of caring for people that don't need to be in an ICU or a ER outside of the hospital. So, I mean, how we do that, needs to be figured out. But that's another interesting thing, is that it would change the whole dynamic of a hospital.
I always, talk to patients about my job is to help people move towards home, because you don't want to be in a hospital any longer than you have to, because it opens you up for so many other possibilities of developing diseases and complications, and it's better not to be there.
Okay, so that's it.
That's it?
That's it.
If you enjoyed the episode, please share us with a friend or give us a rating or a review on iTunes. When I always used to listen to podcasts before we had one and they would say that, I thought, oh, whatever. I don't need to do that. But it was really nice, and we appreciate it.
I still haven't given a rating to any podcast on iTunes.
I haven't either. Actually, but I've thought about it a lot more. So, honesty, maybe I will try and rate a podcast that I enjoy this week. I will.
And
because it is kind, and it helps other people find the show.
You know, the last week was NPR Pledge Week. Mm-hmm. And since we're not part of NPR and we don't make any money, you can enjoy that we have no advertisements and no pledging.
Have any advertisements, no pledges.
And so the only thing we ask of you is to make a free click on iTunes.
Takes like 2 seconds.
So you can also visit our website, placebopodcast.com, for our show notes and to send us any suggestions or feedback.
And you can find us on Facebook. We have a page there, which we really should try and post more things on. That would be good.
Thank you to James Aiken for our music.
And thank you to you for listening. We'll be back with a new episode next week.
Goodbye.
Goodbye.